So let's go for the physiology of cardiovascular system and what are the important questions regarding this from IVMRCS book. So this is normal ECG. You see the ECG has got P wave, Q, R, S and T wave, and this is smaller U wave. So which wave is formed by what? The cardiac cycle has got atrial. The heart has got two atria, two ventricle. First, the depolarization starts from the atria. That causes depolarization, causes contraction. So first P wave is because of contraction or depolarization of both the atria. So P wave is representation of atrial depolarization, ADP, P, atrial depolarization. Then after atrial, this QRS, the leads are measured when you keep this detecting the lead electric signals on this side. You're measuring from this. So QRS complex represents, first is atrial depolarization, then there is ventricular depolarization, QRS complex by ventricular depolarization. During that period atria is repolarizing, but it is hidden during this. So then there is again positive wave. T wave is ventricular repolarization, and U is last remnant of ventricular repolarization, papillary muscles. This is the again for the ventricular. Atrial depolarization, ventricular depolarization, entire repolarization occurred here only. So here is ventricular repolarization, Q is again from this. So P, Q, R, S, T. Anything which causes delay in depolarization of the ventricle. So the wave, whatever changes are happening in the wave, that signifies where is the pathology. QT interval, this is Q, this is T. From here to this is QT, represent ventricular depolarization and repolarization. So this is complete action potential in the ventricles. The action potential in the cardiac muscles, cardiac is basically dependent on the calcium. If the calcium level increases in the body, this increases the contractility and fast, it gets contracted fast, so this wave becomes fast. So this QT interval is decreased when calcium is increased. And if calcium is decreased, so this all process becomes slow, so QT interval is prolonged. So this depend on the calcium influx. So any pathology in the P wave means it is showing disturbance in atrial contraction or depolarization in the atria. So if you try to understand this thing, here is atria, this is right and left atria, and this is ventricle. Both the atria are contracting and this is causing wave, P wave. If suppose anything, the blood is going from atria to right ventricle, if suppose this, there is some stenosis in this, so atria will be enlarged. Here is right atrium to right ventricle, there is tricuspid wall, left atrium to left ventricle, there is mitral wall. If any problem is in the tricuspid wall, atria is getting lot of pressure and it is enlarged, so that is called as, or if from here there is pulmonary artery, from there lungs, so anywhere there is hypertension, right ventricular hypertrophy, the back pressure is there, so changes will be on the P wave. So P wave, if you see, decide this one part is from the right ventricle, this right atrium, this is from the left atrium, any pressure will give increase, this is called as P pulmonale. Any effect in the pulmonary artery pressure, this will give the shape of P wave like this. So abnormalities in the ECG will appear because of electrolyte disturbances. One, hypercalcemia. Just now I have told, whenever calcium is increased, excitability is increased, the QT interval will be shortened. When calcium is less, QT interval will be prolonged. If there is hyperkalemia, this will be having pull effect on the T wave. T wave will be peaked. If there is hypokalemia, there will be push effect. P wave will go down. There will be T wave will flatten or inverted, and small P waves. This will be smaller P waves because contractility. This again potassium is less, and you will get a U wave here. This U wave, it will be bigger size as ventricular repolarization of the papillary muscle. This is U wave is because of papillary muscle repolarization. So it is increasing. J wave is a typical feature of hypothermia. Calcium increase, QT short, calcium decrease, QT prolonged. Increase potassium, long T waves, wide QRS complex. Decrease, you have no pot, no T wave, no T, no potassium, no T, U wave is there, long PR and long QT. Now ischemia, any ischemia of septal will be appearing at 1 to S. AVL, V5, V6, there will be ST elevation. The main thing is ST elevation. There you can see ST, PQRST, ST elevation, ST elevation. Ischemia, ST elevation. If it is lateral wall in the AVL, inferior wall, AVF, F is for the AVF, L is for the AVL. Try to remember lateral, L, AVF. Then V1 to V4, chest slits, anterior septal, V3, V4, anterior septal V1 to 2. Septal 1, 2, 3, 4 is anterior, 1 to 4 is anterior septal. Both are there. 1, 2, S, 3, 4, anterior. 1, 2, 3, 4, anteroseptal, both. So start from the septal, 3, 4 is anterior, combine 2, anteroseptal. So this was about the ischemia, and this is about infarction. What happens? There will be first day arrhythmia may cause early mortality. 1 to 3 days acute pericarditis, this is chest pain. 3 to 7 days papillary muscle may rupture leading to mitral valve regurgitation and heart failure. Rupture septum lead to ventricular septum defect and right shunting. Left to right shunt is there. Ventricular wall rupture lead to cardiac tamponade. These are the complications. Dresser syndrome, immune pericarditis, ventricular system. This is again a question commonly asked in pulmonary embolism. V1 to V3, T wave is inverted. You get a T wave. This T wave. This is V1. V1, V3 inverted T wave. T wave will be right ventricular stale pattern, right axis deviation, right bundle branch block, tachycardia, pulmonary embolism. Heart block, there will be bradycardia. This P wave attempt not correlate with the ECG changes in chamber of heart enlargement. This is normal P wave. This is right atrial enlargement. This is left atrial. Mitral, it will be like M. This is right atrial. Mitral valve stenosis, P wave broad notch. This is P mitral. Tricuspid stenosis, this is tricuspid, this is mitral. Tricuspid right atrial enlargement, P wave tall and peak. This is P wave tall and peak, P pulmonale. Right ventricular hypertrophy, tall T. Whenever there is QR is in hypertrophy, this one will become tall. Right ventricular, PQRS. Right ventricular, tall T in late V1 to V2 and deep S in the V5, V6. V5, V6, S wave. This is QRS. S is left ventricular hypertrophy. Again, S is very deep. Tall R in lead 1 and S in lead 1 very less left axis deviation. This is about jugular venous pulse pressure. You see what is there. Basically, it is showing the pressure in the right atrium. Right atrium to right ventricle, there is tricuspid wall. Left ventricle to in right atrium, left ventricle, there is mitral wall. So pressure here is measured, provides information right atrial pressure. Non-pulsatile jugular venous pulse is seen in when there is obstruction in this. You cannot get pulsatile. A wave, what does it represent? Each wave is representing whenever there is contraction. A wave is seen, atrial contraction, A wave. Tricuspid stenosis, whenever there is stenosis, this having lot of pressure in this right atrium. Pericardial stenosis, pulmonary, anywhere there is further right side pressure, that will give Canon A waves. A waves will be large. So C wave is formed because of sudden closure of all the AV walls, so pressure will increase. So this is a single actually wave, and here is the descent. X descent is relaxation of the atrium. X is relaxation. Then V wave, again you get a positive wave because of filling. Venous return into atria. Atria is getting filling. Venous return, V wave. Then Y is passage of blood from atria to ventricle, emptying. It is relaxation. This is emptying. This is filling. This is contraction. This is closure. How is the cardiac cycle? There is atrial repulsion, atrial contraction, blood is going into the ventricle, both the ventricles. Right ventricle goes into the pulmonary artery, left ventricle goes into arch of aorta. So there has to be this contraction, this relaxes the blood. When this starts contracting, right ventricular and left ventricle, this wall has to close and blood has to flow from here to this. So there is a stage when this wall is closed, this wall has not yet opened. So that is called as isometric, means both the walls are closed and it is contracting. So tricuspid wall and mitral wall are closed in the cycle. So isovolumic means volume is same and there is contraction. So when both the walls are closed, this wall closed, this wall closed, this is isovolumic contraction. When isometric and pulmonary wall close in the cycle, these walls are closed means it is relaxing but it has not yet opened. Isometric volumic relaxation. So cardiac output, how to measure the cardiac output? Stroke volume. In single stroke, around 70 ml of the blood is pushed in one beat. So whatever is the heart rate and whatever is the stroke volume is to multiply it equal to 5 to 6 liters. So 5 to 6 liters of the blood is pumped in a single minute. What is stroke volume? What end diastolic volume minus systolic volume is a stroke volume. Single stroke, this much blood is pushed. So diastolic volume minus systolic volume is the stroke volume. That stroke volume in a minute, so multiply it with the in a beat, multiply with the minute, that will give the cardiac output. Angina, any factor affects contract and decreases the stroke volume. Whenever heart problem is there, stroke volume. Venous return, if it increases cardiac, if the venous return is increase cardiac preload or atrial filling or interstitial volume, which all blood collects in the ventricle before contraction. So increases cardiac output. If end diastolic volume is increased, that will increase cardiac output. Positive intrathoracic pressure, whenever you are giving ventilation, that decreases venous return, decreases preload. that decreases, and diastolic volume. So that will decrease. EDV is decrease, means systolic and systolic volume is same, so that will decrease the stroke volume. So cardiac preload, blood flow to the organs, cerebral blood flow to the brain is about 15% from cardiac output. Renal blood flow is 20% of the cardiac output. Pulmonary is about 10%. This is the question asked: pulmonary, renal, and rest of the thing, brain, skin, you can see here. What are baroreceptors? There are two types of baroreceptors present in carotid sinus at the beginning of internal carotid artery and aortic sinus at the aortic arch. It is a stretch receptor that is felt increasing blood pressure, aortic and carotid, and cause parasympathetic stimulation as in Cushing state. What is there? These are stretch receptors felt increasing blood pressure in aortic and carotid and cause vagus stimulation in Cushing state. So that is causing increase in blood pressure. It is a stretch felt decreasing blood pressure, carotid causes sympathetic stimulation in hemorrhagic shock. Coronary perfusion pressure. So what is coronary perfusion pressure? Aortic diastolic pressure. Diastolic pressure in the aorta minus left ventricular pressure. So this is for the coronary vessels. Whatever diastolic pressure is in there. So we'll stop here and continue next slide.